And I'll start over for the recording. Today we're going to talk about the Medicare claims data that's available via PPRL linkage, not as it's after it's been converted to OMOP, which we've talked about before, but we've made an effort to make, the wonderful people who do this work have made an effort to make the more raw claims format data available, both for those who are more familiar with claims, even though it's not exactly the same format as you might find otherwise, but also for folks to get a sense of, a little bit on the input side and the output side of that mapping process. So it's not, quite so difficult to understand. So before we get started, let's share that screen. Here's our title slide. I do want to briefly review a little bit about PPRL for those who are here and have not run into it before. PPRL is a pretty cool cryptographic technique that allows us to collect information about patients from different data sources. And normally when we collect information about patients from different data sources, they come with different anonymous identifiers. And so it can make it very difficult to know if someone's, EHR data is the same as some data in another data source, because we don't have a way to link them together. PPRL is a cryptographic technique, as I said, that allows us to do this without knowing any personal information about patients when we do this. So it's really quite cool to be able to aggregate different data sources together in this way. As a reminder, this kind of data is only available with a level 3 DUR, which does require an IRB protocol. And when you submit a level 3 DUR, or you submit a revision for a DUR to bring it up to level 3, you get have a chance to select which PPRL data sets that you want to potentially use. And in your justification for the data access committee, you should mention explicitly why you need access to those ones. And you should probably have have some text in the IRB determination letter as well to make it clear that your IRB is aware of these linkages too. So we do have a number of support and learning resources around these PPRL data sets, especially around the CMS, so either the Medicare or the Medicaid data. On Thursdays of our office hours are our days for support for the CMS data, where we're more likely to have experts who are familiar with the data. And we also have some information in our training portal, which I want to show because we've collected a decent bit at this point. And this session will be added to the training portal as well. So if you haven't seen our amazing, super cool training portal, if you go to training material, and then you click on training portal, it will open it up. If you need a quick guide, there's a bunch of training modules in here, we call them, which have cover a variety of different topics. If you need a quick guide and you're not sure where to start amongst all this, you could check out the suggested modules pop out here. But the one that the PPRL information is in, you can search for it by searching for PPRL, and it pulls it up. And when you pull up the module, you see various resources that are associated with that module. And since we've done a variety of things around PPRL and CMS, we have a bunch of resources. They're shown in reverse chronological order. So to see the earliest ones, you scroll down to the bottom. This one here is an introduction to the whole cryptographic technique and what it means. And especially the fact that we only have these PPRL linkages for a subset of patients. In particular, a subset of patients who have the linked data, but also we can only link to data partners that have agreed to that linkage. So we don't have complete linkage. Building on this, we have a little guide for the mortality PPRL data, a little guide for the CMS data, a little guide for the viral variant data. And then, as I mentioned, we've had a few different webinars where we talk about the Medicare CMS data. This is the one, some documentation actually that will go along with today's presentation. And we also talked about the idea of deduplicating patient IDs when you do get information from different sources. So that's it for there. Today's recording will be posted there as well. And I will hand it off to Saad.
Okay, thanks, Sean, for the introduction. Let me share my screen. Okay, can you all see this? So this is just my title slide. Essentially, I'll be talking about the mechanics, some of the mechanics of using this data within the platform. So just where does it live, how you get access to it, and then if you have access to it, how do you import it in your analysis, and then some tips as to, because it's linked data, it's linked to EHR, how to link it to the existing EHR OMOP tables to enrich your data sets, and then I'll finish by giving some high-level statistics. So you're looking here at the homepage, the Enclave homepage. And so the first thing I'll talk about is requesting access to the data. So when you're in the Enclave, you have DURs, data use requests, and you work within your individual team projects. Some of them have level 2 access, which is the de-identified data sets, and some have LDS, the limited data sets, level 3 access. So in order to have access to CMS data, and that is Medicare, Medicaid, whether it's in the OMOP format or the claims native format, you need to, your DUR has to be approved to use the CMS data and PPRL data sets. So there are two ways. If you are creating or requesting to create a new project, when you go to click from the homepage on the data use requests, and then you fill in the details of your title and all the details of the DUR. In here, you have to, this is where you request the data sensitivity, the data tier. And so if you want to have access to CMS, it has to be a level 3 request, which means you need to have an IRB with it. And when it's level 3, you can select CMS. So these are all the PPRL datasets, the datasets that are not coming from, that are not EHR data coming from data partners, but that we are linking coming from other sources, and we're linking via PPRL. So this is how you basically fill in your data use request for a new project, and you add in the CMS dataset as a dataset you want to have access to. That's if you're requesting, if you're a lead investigator and requesting to create a new project. Now, maybe you already have a project that you are working within that is already LDS or de-identified, and you want to request CMS data for the same project. In that case, what you request is just an upgrade of your existing project to be able to use the CMS datasets. And so basically, if you're a lead investigator, you can see your existing open projects and open data use requests in this My Projects DUR. Now, myself, I am not an investigator, and I don't conduct research, or I don't have any DUR, but I have trying to show an example. This is Dr. Gerstin's DUR. He was okay for us showing this. But essentially, here you have a list of all your projects. And so say you have an approved project that is either level 2 or LDS, and then you want to have request the upgrade to be able to use CMS data. You just go here, select your project, and then click on Revise DUR. That will take you to essentially the same data use request form, but in this case, what you'll do is you will add the CMS data set to it as a request and submit, and this will go to the data access committee. And I believe you will need the IRB needs to also reflect that you need that CMS data set. So that is for requesting access to the CMS data. Now, and I see there's some questions on the chat. We can, maybe Sean, you can answer them, or we can answer towards the end. Now, say you have access to these data sets, where do you find them and how do you use them and import them in your analysis? again, from the homepage, you have a link to the data catalog. So the data catalog contains all the data sets that are available in the platform and that you can use in your individual research projects in your workspaces if once your DOR is approved. And so you have the EHR LDS data sets, LDS data, and the identified data that is the OMOP data set, such as person table, condition, etc. And then if you have access, if your project has access to CMS, you will have access to both these data collections. This one is Medicare, and this one is Medicaid datasets. So for the purposes of today's training, we're focusing on Medicare. And so if you go here, you'll see that you have the option to either, it's the same data, but you can either use it in OMOP if you're familiar with OMOP data, or you can use it in, this is the original format. So when we received the data sets from the claims data sets from the vendor that we are working with, they were in this claims format. So you can see here all the tables, and Peter will go into the details of what's in these tables. But these are in the claims format, and this is where you find them. You go to the data catalog, and then you go to the PPRL Medicare data collection. And so either you pick the OMOP format and you have the same data, but in the OMOP format, or you will find the claims format tables in this data collection here. Now, the way to use these, say you have, typically the way you work is you have access, and this is just an example workspace that we have created a while ago for demo purposes. So this is how research will look like if you have access to a workspace. This one, I believe, is approved for LDS data access. But essentially, your starting points generally when you're in a workspace is creating an analysis. And so you go here, you can, if you want to write code, you can create a code workbook or a code repository, or if you want some more like no code tools to analyze data, you can go to Contour. And so you start an analysis, and then you, from the analysis, you can go and select the data sets that you want to analyze. So in this case, if you want to analyze the CMS claims, you go to the data catalog, go to Medicare, and then go to the claims format, and then import these data sets to start your analysis. I'm not going to do that here because this is real patient data and we're recording this, but this, I'm showing you like the mechanics on bringing this into your analysis, and this could be also in code workbook or in other tools. Now, the last thing I wanted to talk about is, so a couple of things. There is this table in the data catalog called the manifest table. So if you go to the data catalog, and then you'll go to LDS data, there is a table that we call manifest, which is here, which gives you information about data partners that are submitting data to N3C, and then information about the release, when was the release, and a lot of useful information for the payloads that these data partners send us. And so one of the questions when you're analyzing PPRL data sets is how many data partners are allowing us to link their data, their EHR data, to CMS. And you can see it in this manifest table here. There are columns here. There is a CMS linkage column. There are also other columns that I mentioned in a previous presentation about like other PPRL sources. But if you look at the CMS linkage column, you can see here that 20 data partners from out of the 78 that for which we have released data are allowing us to link their EHR data with the CMS data sets. And so now the other thing I wanted to show is when you go to the claims data sets, you have you have a column in each one of these data sets, which is the person ID that uniquely identified the patients. And in all of them, you'll see that person ID. That is the CMS, or we call the CMS person ID. So each person coming from that, where we get the data from claims, have an ID, and it has a CMS prefix and then a number. Now, if you want to, this data is linked to EHR, meaning that you can perform a join between these tables and the EHR data that is in the LDS data collection. In order to do that, there is a useful data set that is also in the data catalog. If I go one level up and go to the OMOP format, there is a data set here called CMS person ID to N3C person ID that gives you that mapping between a CMS person and an EHR person that tells you these are the same person. So if you look at the claims, you have the CMS identifier. If you look at the person table in the EHR data, you have the N3C identifier. And this mapping table tells you which patients in claims is actually which records from both are for the same person. So I just loaded it in an analysis here. I can't open the data sets again because it's real patient data, but I can show you at least the schema. So you can see here, this table has a CMS person ID and an N3C person ID, and then the data partner ID, which is the ID that identifies the site submitting the data to us. And so, for example, you can start from one thing you can do is, and I can do it quickly here, is let's load one of the claims data sets. So for example, the members benefits data set. So I'll load it without showing the underlying data. And so this data set, if we look at the columns via the column editor, you can see that this data set has a person ID, which is the CMS person ID. So if you want to bring in records from, let's say, the EHR person table, you first has to join with this CMS person ID to N3C person ID data sets. And then I'll try to do that quickly here. So here I am bringing, so this is the CMS person ID. I want the corresponding N3C person ID. And then I am matching on, so this person ID is the CMS person ID. Whoops, I selected the wrong. So now that I did this matching, I can go to bring in, if I want to bring in EHR data, I can go to the person table, like say the OMOP person table that is in the LDS data collection. And I can join on the N3C person ID. So here I just perform a join and saying this N3C person ID should match the person ID in the EHR person table. Oh, sorry, I should have put it here. And then I can bring in, say, the gender maybe from the EHR data. That's just one example on how to combine the claims with the linked EHR data, and that's via this CMS person ID to N3C person ID. Okay, one last thing, and then I'll pass it to Peter very quickly. And I'm sorry, maybe I've taken more than 15 minutes. I just want to give some high-level statistics about the number of patients we have from the claims that we were able to link to EHR. So about 200,000 patients are patients that we have in the claims data sets that have a corresponding record in the EHR data. So these are the patients we were able to link, and that's coming from 13 different data partners. So you can imagine the more data partners start allowing us to perform the linkage on their data, the higher this number will be. But that's currently the number of people for which we can combine records from both claims and EHR. And that is essentially my that was my part. So maybe I'll pass it off to Peter, or unless you
Quickly,
have
Saad, is that number for the Medicare? The 200,000?
for the Medicare. Yes, I did not. There's an additional. I'll have to check about 40,000 for Medicaid. So that the number I showed is only for Medicare. That's a good question.
All right. Peter, I will rename you so that you are not showing up as Saad number 2. And you can take it away if you like. Peter Leese has been really phenomenal in helping us figure out some how to use this data.
Yeah, thanks, Sean and Saad. Let me just share my screen and just confirming that you can see the slides on my screen now.
Mm-hmm.
Great, thank you. So I guess let me start out by saying my intention here is to really just kind of orient people to these specific claims in the enclave. I really don't do much sort of like getting you from never having seen claims before to like understanding claims. So my perspective is I think most people are probably coming for these claims are going to be people used to doing claims research, and I'm just orienting you to some of the structural and peculiar things in these claims versus other claims that you might be used to, especially other governmental claims that you might be used to. So this link links you out to the documentation that I wrote for these claims tables in the enclave. Pretty much everything that I show or talk about here is in this documentation. So having this link and being able to get out to it once you get access to claims will really rehash any of the information that I'm talking about here. So just super quickly as an introduction to claims. So claims, for people who are unfamiliar, are extremely distinct from EHR data. They really, whereas EHR data directly captures clinical services, claims data indirectly capture services through a billing record. So claims represent clinical services that have been billed for, whether that's on the professional or the facility side. And the way that I teach these different data sources is that claims are much shallower in terms of the data that they cover compared to EHR. So where EHR for a single site will cover every deep aspect of sort of operational or clinical patient care, claims really only cover a shallow portion of that that's going to go out to get billed. So you're not going to hit most operational sort of systems. You're not going to hit granular sort of like nursing documentation and flow sheets and things like that. But a common benefit to claims is that they're comprehensive. So looking at EHR data, you're usually only getting things from the single site or healthcare system that the EHR data is coming from. Claims being at the really payer level as opposed to the provider, you're capturing really 360-degree information for a patient enrollment period. So that is where sort of a big benefit of claims data come in. So really starting to focus now on these claims. So obviously we're talking about Medicare claims here, not Medicaid. And generally, for those of us that work with governmental claims data, we're probably used to working through ResDAC at the University of Minnesota, the CMS sort of official portal and provider for CMS research data. So these data are not from ResDAC, as has maybe been alluded to. These are from a different data vendor that my understanding is really like the preferred data vendor for this type of purpose from CMS. And the files are very similar in ways to what you would be used to seeing from other governmental research data sets, such as LDS or RIF files from ResDAC, but they are not exactly the same. So just as an example here, on the right-hand side of the screen, I have listed out really the source files that we get coming in from the vendor. And you can see this matches pretty closely what you would see from sort of other research CMS data sets. So you have claims getting split out into inpatient and PB and pharmacy and DME, et cetera. To me, there are a few small things, this is where I say they're similar, but not exactly the same. So whereas I'm used to seeing a carrier file, here they have a carrier file explicitly called PB. Sometimes you see outpatient hospital as its own, sometimes that's wrapped into other files. Here, OPL is outpatient facility. So this is where I say, if you're used to looking at research Medicare data, this will be very familiar, but not exactly the same as what you've worked with. I guess looking at my caption here, the other note is that these claims are FFS. So this is only the fee-for-service component of the Medicare claims. I think we have to talk about why. Why are we releasing these data if the claims are already released in OMOP format? So I guess what I would say is that, to me, the effort here is to release these Medicare claims in a format as close as possible to the raw claims that we receive from the vendor. And I think that this is important because the claims, I would say, really often we rely on as the source of truth of the healthcare data. There are lots of funny round peg, square hole things that happen in EHR data at sites. But there's a lot that gets cleaned up and standardized for the purposes of claims data. And so there are often instances where we're using the claims data to actually validate things. And for that reason, I think it's really important to have the data as close as possible to the original format that CMS would be processing it and recording it. So part of this is, for those of you familiar with claims data, claims are often or almost universally structured into these granularities of claims line and claim header structures. That structure isn't possible in OMOP. And so that's a fairly large transformation of the claim structure into something different that affects how you would use it. There are some types of claims data that don't fit natively into OMOP. Examples of that could be diagnosis and procedural metadata. So if those things are important, as often they are in various types of claims research, those things might or might not be in OMOP. So this is a way of providing all of that data that exists in the original claim structure. The OMOP transformation can sometimes very subtly modify some of the claims data. Examples of this that I've seen are sometimes an inpatient stay can be truncated by a day, often on the front end. I don't have a total understanding of why that happens, but so again, to me, it's very important that there is somewhere we can go to see exactly what came through on the claim as the sort of build source of truth. And as I've sort of been alluding to for validation, all of this sort of becomes crucial, particularly when you're looking at something like exactly how many inpatient days did someone have? Exactly how many days of ICU level care did someone have? Exactly how many units of X service did they have? The claim is really the optimal, the unadulterated claim is really the optimal place to sort of view that stuff. And so that, is really a large part of getting these data released out in this sort of raw vendor format. And I guess just to be clear, we keep sort of dancing around these terms of like vendor derived and raw. So in truth, the vendor files that come have been modified slightly. The biggest modification is that many of these files directly from the vendor are several thousand columns, often of largely sort of adjudication and processing flags and variables from their internal warehouse. Most of those I've sort of architecturally dropped so that we have something cleaner, easier to work with and understand, and also just a lot closer to what you would be used to seeing from something like a ResDAC structure. So just to talk about things that will be familiar, again, particularly if you're used to looking at CMS research data. So the claims are structured into familiar files of like 7 to 8 files. So if you're looking for inpatient claims, those are in their own file. If you're looking for claims for durable medical equipment, those are in their own file. Same thing for hospice or home health, as opposed to, a structure where, commercial often comes in one big file of claims that you have to parse. What will also be familiar, sort of related to that then, is if you're looking for a specific domain of information, such as all medications, you will need to be prepared to look at different files to identify, say, all medications or even all COVID vaccinations, because those things can be administered and billed differently. And so you would have to have some understanding of how those services are delivered and which files you would need to look in and union together to get all of those services. This is an extremely common component of claims data research, but obviously this is also different than OMOP, right? So it's sort of different approaches, and depending on the data set, you might have to do slightly different things. So other things that are familiar, column names are very similar to the fee-for-service files that you may be seeing in ResDac. Sometimes they're exactly the same column names. So if you are used to those data dictionaries, these column names and the use of the columns will be very, very familiar to you. Enrollment, if it's needed for cohorting or balancing patient time, enrollment at the month level should be possible from the MBSF file, the Master Beneficiary Summary file. And another aspect that will be familiar is some tables will have recurring claims. So claims where one claim goes out, but it covers multiple services over a multiple time period. So dialysis, infusion, things like that. There are aspects of this data set that I would say are unfamiliar, and things that I've even not really seen done before in other claims data sets. So one thing to know is that these data are not really standardized for things like time period between N3C and the incoming claims data. So at least I don't believe they are. Saad, you can correct me if I'm wrong on that.
Sorry, I missed your statement.
So what I see when I work with these claims is that if I pull a patient in N3C and I pull that same patient's information from the claims, I often will get claims from before that patient's data in N3C.
Yeah, I think that is yes, I'll have to check the time period for the claims data, but it is quite possible that some of it, those payloads are for periods before we started having electronic medical records for that patient. So that is quite possible.
Yeah, so I definitely see it in the operational. I just wasn't sure if what I see in the operational would be the same as what other people say.
Yes, it would be the same.
Okay, yeah. So that is something to know. If you are looking at someone's information in N3C, you have the possibility of getting visits or claims from before the N3C data period for that patient. That is one thing to know. Another thing to know, as we've sort of talked about before and is common with claims, it is very possible and often likely that you will get claims for a patient from hospitals other than the hospital that the patient's N3C data is from, because the claims data are at the patient level, not at the provider level. So you can get information from many different hospitals or health systems for a single patient. It is not just the claims for that patient at that hospital or health system that the patient resides in N3C. So other things that are maybe a little unfamiliar about these claims data, different files in this have different levels of granularity. Some files are headers, some are claim lines. I typically see claims data sets as being either headers or lines, but this data set mixes them depending on which file you're looking at. So for instance, inpatient is headers. Some of the other files are lines. And I try to mark down in my documentation what I see and how I would categorize them, but it's something to be aware of when you're working with the data, especially joining between tables. These claims may include interim or non-final claims. There could be some adjudicatory steps from claims processing captured. I don't have total information on that, but I think it's just a warning to be careful and to double or triple check that if it's relevant to you. And then I think the final thing to note is that the structure of these claims have a prescribed number of columns for certain data types. So diagnoses, procedures, revenue codes in each table have a certain number of columns that they're allotted for each claim. So for instance, I think in the inpatient table, revenue codes have 45 columns. But what we have realized that this means is that the vendor does not truncate that data to that number. They simply duplicate that claim and then continue writing the data to a new row. So I've never ever seen this done before. I call it this repeated header structure, and it was fairly confusing to figure out. This is an example of what I'm talking about. So this is an example of a claim. This is a claim from the inpatient table. I've marked out any possible patient or provider level information. But the claim or the inpatient table should be a perfect header table in this data set. You should have one row per claim. Sometimes you see more than one row per claim. This is an example of a place where we have 2 rows for one inpatient claim. And the reason is because this claim has more than 45 revenue center codes. So on the first line, they write 45 revenue center codes, and then they write an additional 9 on the second line. This is something you have to be aware of and be very careful about when you're processing to make sure you're getting accurate counts, or also capturing all the information that you potentially want. So if you're trying to count the number of days of ICU service in an inpatient stay, and you miss the second row of revenue center codes on a claim, you'll potentially miscount and miss some of those services. This is a bit confusing to talk about. I think the best thing is to, if you're going to use the data, to get access and to run some queries to actually visualize this and see what it looks like, and see what it looks like when revenue center codes sort of extend onto a second row, when diagnosis codes, when procedure codes, et cetera. So now moving on just to, I have so far mainly been working on looking at validating visits between N3C, EHR data, and the claims. And so I thought it might be helpful. Some people have asked me, what has been your process for trying to compare claims to the EHR data? And these are just my sort of itinerant suggestions on the processes that I've followed. The first steps that I do are to match the time periods. So I would identify each patient's min and max visit dates from N3C. I would use those to filter each patient's data from the claims data, just to ensure that the claims data periods for each patient matches what we have in N3C. The other piece then, though, is trying to match providers, because the claims data will potentially bring in data from other providers other than the one that the patient sort of lives in N3C. And because providers and hospitals are not identified, this gets tricky to sort of try and wrangle. One way to try and do this is by matching on dates. So saying that, you know, visits or service A in the claims data matches visit or this type of service in the EHR data. This I find to be pretty tricky because there's a bit of fuzziness, even sometimes for the same service, between the EHR and the claims data. The sort of way that I've tried to get around this is basically by trying to focus on just validating people that only have claims from one hospital for whatever service I'm working from. I mean, this potentially throws out people but it also prevents me from having to worry about people that have services and claims coming in from multiple places and having that throw off whatever calculations I'm trying to do. So, just a suggestion, but if you're stuck and sort of trying to figure out how to proceed, maybe something to think about or follow. And then I've gotten some questions on like, I see this thing, what does this mean? And usually it comes down to, so I see that a patient has this data in the claims, but that data is doesn't exist for that patient in 3C. What does that mean? So this is sort of my quick cheat sheet. So if you see data in claims and that data for a patient doesn't exist in N3C, I would say that likely means the data is coming from a different provider or hospital than the patient lives in N3C. It could also mean that there are just data issues on the ingestion side for the EHR data. Like for some reason, the site either didn't submit that data or it exists in some other format. It's an encounter that's rolled up with another encounter or something. On the flip side, if you see data in N3C in the EHR data, but it's not in claims, what does that mean? So it could mean that the data wasn't billed for some reason. It happened, but for some reason, the provider didn't bill it, and so it doesn't exist in claims. This is only Medicare data, so it could mean that it was billed, but it was billed through another payer. So sometimes this is the case with dual eligibles, Medicare, Medicaid. Or if an enrollment period is different and say someone's on commercial and then rolls over to Medicare during the period of interest. And another issue is just simply that there could be an issue with the EHR data. So, you see something and for some reason in the EHR data, it's maybe a single service in claims, but for some reason it's split into multiple services in the EHR data. That's always a possibility. But so these are just a few sort of suggestions of ways to triage some of these issues that you might see as you're working with the data. And then a question that I have gotten a couple of times is, what about Medicare Part C? Does this data include Advantage plans? It does not. These claims in N3C are fee-for-service only. So in the MBSF, patients actually have an indicator for whether they have any enrollment in Medicare Part C. But since Medicare Part C is really administered through commercial companies, we do not get claims at this point for Medicare Advantage plans or any care that patients receive through Medicare Advantage plans. It's just fee-for-service. And so just to show, much of this information is in this document that I referred to. And you'll get more information at the actual table level. I'll give you sort of some of my findings and observations. I also link you directly out to the corresponding information for the ResDAC versions of these files. We're sort of working to see whether it's possible to provide access to the vendor-provided data dictionary. But I will warn you that I find that data dictionary to be of kind of limited help. It largely really just, I would say this is an example of what the vendor data dictionary looks like. It gives you sort of the short name of a column and then the spelled out sort of name of a column. If you have actual questions about what a data column is, I think you're much better off going to ResDAC and coming to these data documentation files and actually trying to find the corresponding column and getting the ResDAC variable or the ResDAC info on it. So again, these aren't ResDAC files, so you can't guarantee that every single thing in here is going to correspond, but my experience has been that almost all the columns in the vendor data are the same as what you're used to seeing in ResDAC, and this is going to be a much more helpful place to come for data documentation. So let me stop there and just see in the last couple of minutes if there are any questions that anybody has. We're just about at time and not seeing any claims questions. Maybe I'll give anybody one final last chance. All right. I will hand it back to Sean or Saad to, is there anything else we need to do for wrap up?
I think we got it. We'll post the recording in the PPRL training module that I showed at the beginning. And yeah, thank you very much, Peter. That was incredibly enlightening.
Good, great. Yep.
Take
All
care,
right.
everybody. Good weekend.
Bye.